I also welcome Dr. Nigil Haroon to our expert panel. Dr. Haroon is the head of the Division of Rheumatology at the University Health Network and Sinai Health. He is an associate professor of medicine and rheumatology at the University of Toronto and a senior scientist at the Krembil Research Institute and the Schroeder Arthritis Institute, which is a state-of-the-art research facility in Toronto. Dr. Haroon is an internationally renowned clinician scientist in the field of axial spondyloarthritis, AxSpA or AS. He is well published in the area and has been an invited guest speaker in several international meetings. Dr. Haroon also served on the board of the Spondyloarthritis Research and Treatment Network, as well as the medical and scientific advisory boards of the Spondyloarthritis Association of America and the Canadian Spondyloarthritis Association. Dr. Haroon has won several awards, including the Vanier Scholarship and the Jane Bruckle Award of the Spondylitis Association of America.
Good evening, everybody. Thank you all for joining. A pleasure always to be back and present on AxSpA. So today I will be talking mostly on pathogenesis and the early stages of presentation and diagnosis, and Dr. Inman will be following with how we treat patients with ankylosing spondylitis and the recent advances. So let me share my screen 1 second. Very good. So the whole idea is answering the question, is it in my genes? What actually causes ankylosing spondylitis or axial spondyloarthritis? So the outline of my talk is mainly discussing on the genetic causes of AS. In the beginning, we'll talk about HLA-B27, a gene that most of you would know. Cover a little bit on the non-HLA genes and then go on to non-genetic factors. And at the end, hopefully we'll have time to cover the clinical presentation of axial SPA. So axial SPA and AS, as it is popularly known, is really caused by a complex network of cells and molecules. But we don't really know the root cause of AS till date. It's been over 50 years since the discovery of HLA-B27 and the identification that genetic factors do play a role, but yet we don't exactly know how the disease is caused, what are the key genes. But clearly, genetics appears to be the predominant cause and some influences from the environment. The earliest clues came from family studies and twin studies. If you look here is a study of 6 monozygotic twin pairs and 20 dizygotic twin pairs. So this means that these are monozygotic pairs, almost identical twins, and dizygotic means they have some gene sharing, but they are not identical, right? And this number here refers to the number of times or the percentage where if one twin is affected, the second twin is also affected with AS. And you can see if they are monozygotic twin pairs, greater gene sharing, 50% concordance of disease, as opposed to only 20% concordance. So only 2 out of 10 twins, if they're dizygotic, would have disease in both twins. Okay, so that clearly shows that if you have greater gene sharing, higher likelihood of the disease occurring in both individuals. So probably genetics has a role. Similarly, if you look at the degree of relationship within a family and the concordance of disease within the family, as you go from third degree of relationship to second, first, and twin, you get closer and closer with increasing gene sharing. Let's look at how the concordance goes. Clearly, with twin, it's 50 to 60%. First degree relatives around 10%. So if you're asked the question, if there is one member in the family, what is the chance that another first degree relative within the family will be affected? First degree relative means, if you're for parents, it will be the kids, siblings, parents. So all these are first degree relatives. First degree relatives is 10% chance only. So if you look at the flip of that math, 90% chance that another person within the family will not get the disease. So, and the same number, 90% chance that the next generation or the kids will not get the disease. Okay, so what's up with this HLA-B27? Let's look at how a normal immune response happens. Okay, so this is an antigen presenting cell, and antigen presenting cells function in our immune system to present to our army of immune cells if something extraneous enters the body, because a virus or a tumor is not good for survival. So the antigen presenting cells would capture this. And here I've given an example of a virus. The antigen presenting cell has captured the virus. The virus is composed of many proteins. The immune system cannot really look at the entire organism like that. So it has to be broken down into individual components and proteins and peptides, which ultimately become antigenic or elicit an immune response. So how does it elicit an immune response? Each of these components has to be presented by the antigen presenting cell on a plate to our immune system. And our T cell within the immune system can come, recognize this combination of the antigen on that plate and recognize it as self or as foreign. If it sees that it is just a thyroid antigen, the immune system does not cause any issues. It goes on as normal. Now, in an autoimmune situation, of course, the antigen may be abnormal, and then you get thyroiditis and hypothyroidism and things like that. So HLA-B27 essentially is this hand that presents antigen to our immune system, so that our immune system, our infected cells can be killed, and our survival is increased. So that is HLA-B27. It's actually a great gene. It's a great molecule, and the gene behind its B27 gene is a great gene. And why I say that is because those who are HLA-B27 positive, if they get hepatitis C virus infection, there is a lower chance of them developing cirrhosis, because the hepatitis C virus can be presented like that beautifully on B27, and our immune system can try and get rid of it, or at least keep it under check. Similarly, HIV patients who are HLA-B27 positive tend to have less chance of progression to AIDS. So progression of HIV virus infection is also lower, because B27 has the ability to present HIV antigens to our immune system, so our immune system can keep it under check. So actually, it's a very good gene. Unfortunately, HLA-B27 also might be presenting some antigens that may be cross-reacting with our joint antigens and leading to AS. So that might be the case. So that is HLA-B27, and this junction where the HLA-B27, the antigen, and the T cell meets is called the immune synapse, and that is where the most of our immune activity happens. So why do we think HLA-B27 is important? First of all, the prevalence of B27 in AS is around 85%, whereas HLA-B27 in general Canadian population is only 7%. So clearly, there is something about HLA-B27. If you introduce B27 to a rat that usually does not develop any disease, just the introduction of B27 itself leads to arthritis, as you can see here in that second figure. It can cause changes of psoriasis, like nail changes, inflammation in the skin. You see the inflammation in the skin also in the tail here, psoriasis-like changes. And in the gut also, compared to normal gut, you see that there is significant inflammation happening in the gut. So almost all the features of AS and associated conditions can be seen just by expression of HLA-B27 in the rat model. So that was for another strong indication that B27, it's not just a bystander, it may actually be causing disease. So how does B27 cause disease? So even after 50 years, we don't know exactly how, but there are a few theories, okay? So for the first hypothesis is that just like HLA-B27 presents hepatitis C and HIV antigens, it may be presenting some antigen that CD8 T cells in our immune system may be recognizing, and this antigen may be cross-reacting with another antigen in the SI joints or in the enthesial tissues or in the rest of the musculoskeletal system. Maybe it is cross-reacting with an antigen in the eyes causing iritis. So that may be one of the mechanisms, and is called arthritogenic peptide hypothesis, because maybe this peptide is arthritogenic or can elicit arthritis or cause arthritis. The second mechanism is that B27 may actually not be participating in the immune system at all. B27 itself may be accumulating inside the cell and causing a lot of inflammation. And that is called the misfolding hypothesis because B27 tends to accumulate and misfold. The third one is that B27 may be taking on abnormal shapes on the surface, and instead of our regular immune response, maybe other abnormal immune responses may be triggered because B27 has this tendency to misfold and form abnormal structures. You can clearly see it looks different from the normal appearing B27 on the surface. So maybe it is taking a different shape, and the immune system thinks this is abnormal, and you get reactions. So there are a lot of experimental evidences supporting each of these hypotheses, but nothing really very strong so far pinpointing against one. But as I will show you in very recent developments over the last couple of years, there may be a greater emphasis on looking at the arthritogenic peptide hypothesis, and maybe there is an antigen that we are exposed to that is driving this disease. Could it be a viral infection that we experience? Could it be exposure to smoke? Could it be pollution? Could it be in the drinking water? Could it be a diarrheal illness that we had at some point during our life? So those things are yet to be worked out, but there is more and more evidence mounting, pointing towards perhaps an antigen-driven process in AS. So this is where we'll talk about the new discoveries. So if we go to understand the latest discovery, let's go back a few years where Dr. Inman actually studied the T cell receptor, or that immune cell receptor that recognizes HLA-B27. And normally, when you look at T cells in our immune system, if it has the opportunity to see multiple antigens, you will see a lot of different kinds of T cells. But if the immune system is driven by one or two antigens, for example, in AS, if the immune activation happens because of specific antigens, then you will tend to see more T cells that recognize that antigen. It's quite natural because they tend to proliferate and increase in number. So when you look at 100 T cells, instead of each of those 100 T cells being recognizing 100 different antigens, you may say 10 or 15 recognizing only one antigen. So that shows that maybe that antigen is driving the immune response. So let's look at the T cell clones in B27 positive AS patients, B27 negative AS patients, B27 positive healthy controls, and just back pain controls without any B27. First of all, you can, and what you see in the y-axis is the number of patients, and on the x-axis is the total number of T cells that recognize specific antigens. Okay, so if you look at 8, 7, 6, that's quite a high number, and you see that being represented only in B27 positive AS patients. You don't see a high number of T cell clones in B27 positive healthy controls or B27 negative cases or back pain controls, showing that there seems to be a T cell driven by specific antigens in the B27 positive AS patients. So maybe there is T cell that is recognizing specific antigens. So fast forward to this study, which specifically looked at the arthritogenic peptide hypothesis, and I'll explain this better with this figure. So in this study, patients with ankylosing spondylitis and uveitis were included in the study, and in both uveitis and AS, both tissue and blood was taken. So for AS, peripheral blood, of course, and tissue is actually from the synovial fluid or the joint inflammation. It's very difficult to do a biopsy of the spine to get actual tissue from the back. So they took fluid from the peripheral joints because there was swelling. And for uveitis, obviously peripheral blood, and the tissue is eyes because it's uveitis or eye inflammation. So eye fluid was taken out. And what they did is they isolated the peripheral blood cells, the synovial fluid cells, and the eye cells out, and they did something called single cell sequencing, in which each individual cell was sequenced, and the type of T cell on each of these cells, each of these patients was identified. All the different types of T cells was identified. And what they found was an expansion of this particular T cell called V beta 9 T cell with a particular motif with a beta chain and an alpha chain. That is, a specific T cell seemed to be expanded, just like we saw in the previous study done by Dr. Inman. But this team went to be more specific and identified a specific T cell that seems to be expanded. And you can see that that expansion is more in the tissues compared to blood. So yes, there you find some in circulation, but when it gets to the eyes, when it gets to the synovial fluid, they increase a lot, showing that they tend to home in on the joints in the eyes, uveitis, maybe in the gut causing colitis, maybe in the back causing sacroiliitis and spondylitis. So there is expansion of T cells. Perhaps it is driven by an antigen. They looked at what antigen could be driving this. Could not pinpoint exactly one or two, but there were clues that maybe there is a gut-derived antigen that is driving this. Okay, now why is this important? So remember that V beta 9, so that is the T cell that was very recently identified. So let's look at what that is. So you have so many T cells in our immune system, of which this particular V beta 9 T cells are only around 4% of all T cells. We all know that in cancer chemotherapy, what happens? We ablate our marrow. We get rid of all the immune system, all the blood cells, and that's the reason why we are immunocompromised and you get infections, and that's the biggest cause of mortality and everything post bone marrow transplant and post chemotherapy and things like that. But imagine if you could only get rid of 4% of your T cells, remaining 96% is available for our immune system to be active. But that maybe the pathogenic T cells that are causing disease lies within the 4%. Then you have a very targeted immunotherapy that could get rid of only pathogenic T cells, and that's very, very, very promising if that is indeed the case. Okay, so that's why there is so much enthusiasm around this. So here is an example of a patient. So their company developed an antibody that actually binds to that specific T cell. Okay, so it was tried on this patient way back in 1983. The first symptoms started in this patient. By 3 years, 1986, the first diagnosis was established. B27 testing was done in this patient in 99, so quite a bit late. Probably they were on anti-inflammatory agents, as you can see here, starting at low dose and then increasing to high doses of anti-inflammatories. By 2004, anti-TNF therapy became available in that location, and the patient got access to anti-TNF therapy. Patient was on anti-TNF therapy for almost 5 years, failed therapy, went on to receive stem cell transplantation. After that, perhaps he was able to access somebody who thought stem cells could cure the disease. Unfortunately, it did not. Fast forward to 2016, hip disease was really troublesome. He got a hip joint arthroplasty, and then fast forward another 3 years, and then this anti-TRV beta 9 monoclonal antibody became available in his location, and he became a subject. So in 2019, he received the antibody first and with increasing doses subsequently up to 2023 when the publication was done. For the 4 years, the patient received this antibody against the T cell. Okay, this is what happened. Okay, let's start. We'll start looking from the time the patient got the antibody, and this is AxSpA, so high disease activity with the antibody. This is 2000. Where is it? 2000 and yeah, somewhere here. You can see that the inflammation disease activity is dropping. What you see here is the spinal mobility. You can see the spinal mobility has improved. What you see below this again is neck rotation that is significantly improving on treatment. So you can see overall there is a decrease in inflammation, improvement in spinal mobility, neck rotation, and all disease activity measures seem to be improving and sustained over 4 years. So very promising. This has gone on to a phase 2 study, which also was positive, but it's very early days, something to look forward to in the future. Okay, so that's about B27 T cells and the most recent advance in the T cell targeting field. Dr. Inman might be talking a little bit more on that during his treatment talk. Let's go back to our B27. And I mentioned that B27 is present in 85 to 90% of AS patients. However, if you take 100 individuals with HLA-B27, this happens very frequently in our clinic, right? Patients come in saying, hey, doc, I've got an HLA-B27 positive test. When should I start treatment, all right? So out of 100 people with HLA-B27, only 2 actually have AS. 98% of individuals with B27 walk out of that room without a diagnosis of AS. That is because B27 is so non-specific. And as I mentioned, 7% of Canadian population has B27, but disease is present in less than 1% actual AS. Okay, so it is a normal gene. So what causes AS in those 2% of patients? What drives those TRV beta 9 cells? What is the driving cause of that? So there was really no clue till the advance in genome sequencing. So genome-wide association studies were done because the whole genome mapping was done, polymorphisms were identified, and we could study in large numbers these polymorphisms within the genes in AS patients and controls, and multiple genes got picked up beyond HLA-B27. Of course, B27 is the strongest, but there were many others that are close by there. And ERAP1 was of particular interest to us. You can see the table here of multiple other genes that got picked up. But the interesting thing is, you look at this number, that's the odds of developing disease if that gene is present. And for HLA-B27 is very high, 90. But once you leave B27 and go down the list, all the others have very, very, very small contributions. And together, they may be playing a role, but nothing close to HLA-B27. So we still haven't, I don't think we have still have cracked the code of that unique combination of 3 or 4 genes that come together with B27 and cause disease. But ERAP is very special, and we had a very close interest in ERAP because it is closely linked to the hypothesis that we mentioned earlier about how B27 might be causing disease. Okay, so let's go to our antigen presenting cell, and let's say this is the antigen that comes out of that virus. Okay, so that is broken down within our cell by a molecule called proteasome. It breaks it down into antigens. It enters an organelle in the cell called ER, or endoplasmic reticulum, where ERAP trims it down into an appropriate length, and that when it's perfectly fitting on HLA-B27, it goes to the surface and you get a normal immune response. Now, if ERAP is abnormal, instead of a perfect fit of B27 and the peptide there, you may have abnormally long peptides sitting there because ERAP is abnormal. Now you on the surface, you have the B27 presenting abnormally long peptides, or we already talked about B27 misfolding. That misfolding can increase and cause a lot of stress and cytokine release, or you have abnormal surface expression of these cells leading to abnormal immune responses. So you can see why there is a lot of interest in ERAP, because we have been trying to find out which of those hypotheses of B27 is actually playing a role. Now you have another gene in the same pathway that could explain. There was a lot of study around that. Straight away, we'll go to ERAP1 knockout studies, because that is very interesting. What was identified in the polymorphism association in ERAP is that if you have ERAP1 activity was higher in patients compared to controls. So the idea was, if ERAP1 is higher and is closely linked to B27, can you reduce ERAP1 activity and reverse disease? So that idea was used in the animal model, where in the B27 animal model, where these are animals, B27 positive rats with ERAP, and these are rats without ERAP, and this one is where one gene is knocked out, both are not knocked out. And you can see that the arthritis has improved, which is what you see here. Compared to the diseased rats, the arthritis has improved when you knock out ERAP. So it seems to be interesting. However, look here, what happens to the colitis? When you knock out ERAP, the colitis seems to be worsening. So this brought the idea that, okay, AS patients can have psoriasis, uveitis, IBD, and Crohn's colitis. arthritis of the back, arthritis in the peripheral joints. Maybe, the different tissues are getting inflammation because of different mechanisms. So to really control it, we really need to understand what is a predominant immune process within a patient. And really, we need to be doing personalized medicine, understanding exactly for each patient what is the best treatment. That may be the reason why when we try and treat blanket for same drug for every patient, you only get 50 to 60% response because 40% are not responding. That was not the best treatment for them. Okay. So finally, we'll put everything together. We have the ERAP B27 story antigen B27 unfolded protein response, and then this B27 comes to the surface. You get the CD8 T cells, and you get an immune response. So where does this antigen come from? There is a big hypothesis that probably it is coming from the gut. Maybe it's in our diet. There are a lot of patients who believe that a low starch diet and a low carbohydrate diet is good for them, and they feel that when they go in and have a pizza one day or some bread one day, they tend to feel that inflammation and their joints feel warmer. So it might be working for them. So is it linked to the microbiome? In fact, if you look at patients' bowels, there are changes in the microbial organization. There is microbial dysbiosis or change in the in the structure microbial colonies in AS patients compared to healthy controls. If you look at patients in different cohorts in different countries, oftentimes you see the dysbiosis, but it's not caused by the same organism in the different countries. Obviously, because the diet is different, the environmental situation is different, and that's why we have not yet been able to pinpoint. But there seems to be a difference there in the gut, and as a result, our Paneth cells or sentinel cells within the gut that recognizes these produce a lot of cytokines, interleukin 23, that further expands immune cells. These immune cells can be seen in the blood circulation. Perhaps they're coming from the gut into the circulation, and then they go into the joints and cause inflammation within the joints, getting arthritis. Okay, so maybe there is a gut origin of everything, ultimately ending up in the joints, causing inflammation. I think this is probably the last part on the immunopathogenesis side, where I wanted to show you one patent pending discovery that we made in our lab here. So this is a discovery on a molecule called macrophage migration inhibitory factor, and a big team has really worked behind this discovery, and we are now working with a company trying to take it to clinical trials and bring it to help patients with AS. What we found was that this MIF can drive inflammation, it can drive bone proliferation, two cardinal features of ankylosing spondylitis. And most of the molecules that you have known so far, like TNF and IL-17 and everything, are known to drive inflammation. Quite often, especially if you look at rheumatoid arthritis, instead of bone formation, it actually drives bone loss and erosion. So MIF, on the other hand, could drive bone formation, which is actually the cause of spinal fusion. So we got very interested. Maybe MIF has a key role. So we went ahead and knocked it down in an animal model, showed that the disease could be reversed. We used an inhibitor against MIF and showed that the disease could be reversed. We worked on finding out the different interactors and drilled down on the mechanism by which MIF is driving inflammation and bone proliferation. So three big papers came out of this work. I won't be going into the details, but I'll just show you this, that with the help of our collaborators in Korea, we actually looked at the spinal tissue of AS patients and compared it to osteoarthritis. And what you see is very high levels of MIF expressed in the spinal tissues of AS patients compared to nothing in controls, showing that MIF is also present in the actual place where there is a lot of inflammation causing pain and bone formation. So still early days, but a lot of progress in this field as well. So to summarize the pathogenesis side of things, I've not covered everything in the interest of time. Just talked about the familial concordance of disease, the twin studies, the family studies, the role of HLA-B27, the non-B27 genes that have been discovered, which all have small contributions, but together they may be massive. And the latest discovery of the T cells, that the V beta 9 T cells, which forms 4% only of the T cells that we have, which may be driving disease, a potential target for treatment. We talked about the gut origin of potential T cells and immune cells being driven by microbial changes, maybe. And finally, we talked just very briefly about the latest discovery of MIF driving inflammation and bone proliferation. Very quickly, I want to take you through the clinical, just set the stage for Dr. Inman to talk about treatment. I'll just very, very briefly and quickly go through some of the slides on how patients present with spondyloarthritis. So inflammatory back pain clearly is the most important presentation. But along with that, you may see structural changes when X-rays are done, if it is of sufficient duration. Changes within the sacroiliac joints may be seen on X-rays. But sometimes, it may be very early. Changes have not already happened in the SI joints and X-rays, or all patients don't develop structural changes. It's predominantly an inflammatory disease without much structural changes. In both situations, you need to do an MRI to look for inflammation. And what you see here bright is actual inflammation in the sacroiliac joints. And that is sacroiliitis, which can, in the correct context, and can be diagnostic for AS. Here you see inflammation in the peripheral joints. Peripheral joint inflammation can lead to bone spurs, plantar fascia spurs, and heel spurs can happen. Peripheral joint involvement is usually seen in around 30-40% of patients, not in all AS patients. Bowel inflammation is seen in around 10%. Psoriasis is seen in around 10%. Eye inflammation is seen in around 30% of patients. So uveitis, Crohn's colitis, and psoriasis are strong associations. But the dreaded long-term complication for most people is the spinal fusion, leading on to bamboo spine and stooped posture. Okay. Long-term complications are not just restricted to the spine. There is increased vascular mortality. And vascular mortality, if you look specifically, there is a 36% increased risk of death, 60% increased risk of death from strokes, 35% increased risk from heart attacks. And these are relative risks. And it came from a study done in around 25,000 AS patients in Ontario compared to 100,000 controls. So you need a very, very large population study to show this, because the actual risk is very low. You have to compare the risk of having a heart attack and death from that in a 30-year-old with AS to a control with AS. So very, 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 very low risk of having a heart attack at 30 years or 40 years of age. But you can imagine having AS for 20 years, 30 years, or 40 years. By the time the patient is 60 or 65, they would have accumulated more damage in the coronary arteries than a control or non-AS patient would have. So if we treat patients at the very early stage from 35 or 40 years of age, by the time they're 60, their coronaries and heart should be as healthy as anybody else. So that's the importance of studies like this. Okay. Those who have PSA may also have some nail changes, skin changes, especially peripheral joint involvement and dactylitis-like changes. So when there is association of AS with psoriasis, these changes also can be seen. Okay. This used to be the situation. This graph actually shows, the first graph here shows the age of onset of symptoms. This is the age of diagnosis in males. This is the age of diagnosis in females. You can see a 10-year gap in diagnosis in males and almost 20 years before diagnosis made in females, because the concept before was that females don't develop AS. If there is back pain, it's likely just pain syndrome or fibromyalgia, not AS. Now we know that males and females almost have equal prevalence of AS. So the clinical level of suspicion is much different these days, and the gap has decreased, but still not perfect. Okay. How do we try and reduce the gap? Understanding all the things that we mentioned about the inflammation elsewhere, the peripheral arthritis, the use of MRIs, use of blood work to look for ESR, CRP, doing the test where appropriate for B27, making sure that we don't miss Crohn's colitis and psoriasis. And these are the early ways to do it. I think we'll skip that. And also distinguishing the type of back pain may also be important. And this is, I think, an important message to take home. All back pains are not same. It is not a good, perfect tool, but at least it's a start. Back pain that starts in somebody who's 70 years of age is different from 35-year-old with chronic back pain. Back pain that lasts for 1 week is different from like 3 months or 4 months of back pain, right? And back pain that starts after going to the gym is different from insidious onset of back pain that you can't really pinpoint when did that pain start, as opposed to I was lifting a bag off from when I was getting off a plane. So that's instead of acute onset. Back pain that is associated more with exercise is different from back pain when you're at rest, and especially in the morning, a lot of stiffness is seen in spondyloarthritis. So, summarizing, young age of onset, chronic back pain, which is insidious in onset, associated with stiffness and improving with exercise, is more a feature of AS like back pain. Okay. Imaging is great, but unfortunately it is not really perfect. And the image here I put is because our pelvis is actually tilted down and forward. It is not perfectly anterior-posterior. So when we do X-rays, it's very difficult to see the SI joints. This is a CT scan image, and you can see if you do CT scans, you can see the SI joints well. But CT scans have a lot of radiation, so it's not a, and also there is a wait time in getting CT scans. So it's not a good tool to just blanket use in everybody, unnecessary exposure to that much radiation. So we have to perfect it. And this is just to show you, this is more or less a normal SI joint, and you can see on this side there is erosion and partial fusion happening. I'll click through this, and this is an MRI showing changes of inflammation there, changes of erosions and damage happening there, and some ankylosis happening there. So there's a lot of advance in the way we read MRIs, the techniques used for MRIs, and also our ability to identify small changes in X-rays as well. So imaging advances, increased awareness in clinical case detection, all of these have hopefully led to significant improvement in diagnosis. Finally, I'll leave you with the concept of axial spondyloarthritis. We always talk about AS, and ankylosing spondylitis. But now axial spondyloarthritis is a term used. So let this be the last slide where I'll leave you with this concept. So axial spondyloarthritis refers to the full spectrum of AS. Okay. And let's start even before that spectrum starts. So somebody's born with HLA-B27, so they have a genetic predisposition. At some point in their life, they're exposed to something that triggers back pain. Okay, so that at that very early stage, if you do X-rays are negative. So patients technically don't have ankylosing spondylitis because AS or ankylosing spondylitis is defined by X-ray changes. But because it's an inflammatory process, if you do MRI, sacroiliitis is detected. So this would be a non-radiographic axial spondyloarthritis. After a few years, the X-rays become abnormal and it becomes a radiographic axial spondyloarthritis or AS. And after a few years, spine also can get fused and you can get advanced AS. So sort of genetic predisposition, early non-radiographic axial SPA, radiographic axial SPA, advanced spinal fusion axial SPA. So that's sort of the natural course of disease. But fortunately, the majority of individuals either stay here without developing disease or they may have only sacroiliitis and MRI. A very small proportion actually becomes AS, and even smaller proportion actually goes on to fusion of the spine. So this is not the outcome in the vast majority of individuals, fortunately, even without treatment. And with treatment, there has been a huge amount of improvement, and the prognosis of patients with AS has significantly changed over the years. So I think I'll stop there in the interest of time.
Thank you, Dr. Haroon, for sharing all of that information and the great insights and knowledge and expertise. And I know that we do have time for a few questions here before we take a short 10-minute break. We'll take a 10-minute break just after 8 o'clock. But there are some questions here, and I'm just going to, I see Dr. Inman's slides are up. We're just going to pause on that for a moment. So one question here is, and you talked about the gut a little bit, so these questions are associated with that.
Sure.
Is there any association between AxSpA and colitis?
Yeah, so two or three different ways to look at it. First of all, the clinical association between AxSpA and colitis. If it is ulcerative colitis specifically or Crohn's colitis, yes. So the numbers we talk about are if you do just endoscopy and you do biopsies in the gut in 100 individuals with AS, 60 to 70 of those individuals may show a little bit of inflammation. Okay. So there seems to be a very strong connection as regards to inflammation and AS. However, the vast majority of them don't have overt colitis, like they don't have recurrent diarrhea, they don't have blood in stools, they don't have lost weight. And if this biopsy was not done, this would never have been detected in the entire life. So there's something there that is driving it. Now, out of those 100 AS patients, 10 may have overt colitis with diarrhea and all, and that leads to a diagnosis of Crohn's or ulcerative colitis that leads to treatment. And the good thing is that the treatment for AS is most often effective for the treatment of Crohn's colitis as well. So that is on the clinical concordance, just prevalence wise. However, there is also another thing that needs to be kept in mind. I mentioned 30 to 40% of AS patients have peripheral arthritis as well, right? And the disease activity in the bowel is strongly correlated with peripheral joint arthritis, not so much the back pain. So you can have a flare in the bowels with a lot of inflammation, but the back is doing well. But there is a higher likelihood where the knee or the ankle can swell up at the same time, as opposed to the knees, ankles, and the bowel may be quiet, but the back can flare. So there doesn't seem to be an association between the gut and the back, but there is a strong association in the disease activity between the bowel and the peripheral joint. So that's the other interesting observation.
And then there's another question here, and it's almost the same question. Just what's some of the latest research on treatment that can control spondyloarthritis and Crohn's?
Yeah, so I'm pretty sure Dr. Inman will cover this in great detail. So I would hold it for that.
Okay, so we'll hold it for that. There is a question here. I'm just trying to get them related here. So, has there been any research on how diet and eliminating inflammatory foods can positively affect the condition?
Yeah, so to answer the question, straightforward, easy answer is no, there is no strong proof, and it's very difficult to prove. All right. First of all, maintaining a constant diet for a sufficient period of time and then controlling that with another form of diet. These are all very, very difficult studies to do. So there is no direct proof. But if you go back many, many years before all these treatments were available, if you take simple treatments that were available to patients with rheumatoid arthritis and other inflammatory diseases, they would be admitted in the ICU, given only IV fluids, and give extreme caloric depletion. And then naturally the adipocytes come down, the adipocyte-related cytokines come down, called adipokines come down, the inflammation comes down, and the patients get discharged. So there is definitely something with the caloric restriction. Is that caloric restriction primarily because of carbohydrate restriction and all? Anecdotally, patients report that, but I don't think scientifically it's been proven.
Okay, thank you for that. Another question here is HLA-B27 connected to genetic history from one region or country?
Very, very good question. So the association of B27 with AS and the strength of association varies with the place where this testing is done. B27, if you look at the map of B27, it is actually a mirror image of let's say malaria, for example. Or so there might be a survival advantage of B27 against some infections, or the reverse, maybe during the migration of individuals from, like, say, the Caucasus Mountains across, and they came over to Haida Gwaii and then down there, it's possible that during that migration, those who were B27 positive survived, and the B27 negative individuals were succumbed to some form of infection, right? So if you go up northern BC and look at some of those populations, every other person can be B27 positive because of very high prevalence of B27. It doesn't mean every other person has AS. So if having B27 in that population is not a very high risk, because there's 50% chance you could have AS. But if you go to Japan, the prevalence of AS, as opposed to 7% in Canada, prevalence of B27 7% in Canada. In Japan, it's only 1%. So having B27 there is a much higher risk, because the denominator of B27 in population is very low. So clearly it is important in diagnosis, but the chance of finding B27 positivity in AS is much higher in Canada than in Japan, for example. Yeah.
That's interesting. I wonder if we can try to squeeze in a couple more before we take a short break before Dr. Inman comes on. Can pollution or environmental matters cause AxSpA?
Again, no definitive proof. So environmental influences are the strongest one in connection with arthritis has been shown mainly with rheumatoid arthritis, and there is sort of a scientific path that has been shown, and that is related to smoking. And for example, in rheumatoid arthritis, if there is smoking in a genetically susceptible individual, an enzyme can be triggered. The enzyme leads to antigenic change, leading to rheumatoid arthritis. That kind of a gene environment interaction specifically has not been shown so far in AS, but maybe the latest study that I showed about T cell proliferation, that is very specific, that seems to be driven by an antigen. If you are able to find out what that environmental exposure is, perhaps we could identify what needs to be avoided. Yeah.
Thank you for that. I see one of our directors of the board, Anthony Florendo, has asked a question. I think that you've already covered it, but is there an AS-friendly diet?
Oh, yeah. So wish we could do that study and show that. But in general, if you at least from what our patient says, that exercise and low caloric diet restriction and a healthy diet with lots of fruits and vegetables should be good. But at least some of the patients feel that if they have a lot of starch, it doesn't seem to be helpful, but not proven, obviously. Yeah.
Okay, great. So we're just going to pause there. I see that there are many other questions. We're going to try to, like I said, we're going to have a 30-minute open Q&A segment following Dr. Inman's presentation. So we are going to take a 50-minute break so everyone can stretch. Why don't we come back here around 8:12? So 8:12 Eastern time, and we will queue up Dr. Inman. Thank you so much, Dr. Haroon.